request Dr. Kondaveedu to bring the moment.
Okay friends, I am going to share my experiences with this wonderful external DCR surgery. So we all know the morning I told you the anatomy, how this tear pathway occurs. You can see the site of this blocked area is in the nasolacrimal tract. This is the normal usual blocking area. So coming to the this entire topic goes like 10, like a 10 commandments. So there are 10 symptoms, 10 signs, 10 investigations, 10 differential diagnosis, 10 instruments, 10 indications, 10 contraindications, 10 types of DCRs, 10 surgical steps, and 10 complications. When our ophthalmologists were doing DCRs for hours together, like 3 hours, 4 hours, the theatre staff used to run away from, take the leave and run away from the hospital the day when they post the DCR surgery. That was the usual scenario during the initial times of this DCR surgery. But because of this bleeding and other complications, they avoid and they hate the surgery of DCRs. But what I did is, I cut the entire surgery into 10 steps and make it beautiful surgery so that everybody loves the surgery, should do the surgery themselves, not referring the cases to anyone. So coming to the symptoms, usually they have watering of eyes, or mucoid discharge, or mucopurulent discharge, stickiness of the lids, swelling of the medial canthus, pain, maybe there, may not be there, nasal discharge, nasal blocks, and redness of the eyes, and last is Rocklass. Rocklass is a test, a symptom and also a sign also. Rocklass means regurgitation of pus on pressure over the sac, lacrimal sac. So coming to the signs, again they have epiphora when we observe. All these things will repeat. Mucoid discharge, mucopurulent, and matting of lashes, and punctal abnormalities we should observe. Lid abnormalities we should observe, whether there is any entropion or ectropion of the lid, why the patient is coming with the watering of the eyes, as conjunctival congestion is there or not, or lacrimal sac swelling is there or not, if the swelling is there, whether it is tender or not, if there is tenderness, you should stop the surgery, you should treat the acute rhinosinusitis and then proceed with the surgery. And upper respiratory tract infections or nasal abnormalities we should look for. And Rocklass again, here you can see the Rocklass. When you press this lacrimal sac area, you can see the pus. Once this is positive, you need not do any syringing, because this itself shows that lacrimal canalicular are normal. The block is at the level of NLD. So you can straight away proceed with the DCR surgery. Once this Rocklass is positive, no other test is required. Coming to the differential diagnosis, foreign body may be there in conjunctiva cornea while the patient is having watering. Dry eye may be there. Dry eye, they have watering, lot of watering because of instability of the tear film. Conjunctivitis may be there, either allergic or infective. Cornea may be either damaged, abrasions or cataract or dystrophies. Entropion, ectropion, injuries, tumors, all these things can cause watering of eye. Congenital glaucoma may be there. Bell's palsy may be there with lack of thalamus causing watering. Crocodile tears may be there because of geniculate ganglion defects. Upper respiratory tract infections or nasal abnormalities, all these can cause watering of eye. And last is Centurion syndrome. What is this Centurion syndrome? Centurion syndrome means they look like Roman centurions. Young males, 14 to 18 years males, they come with the watering of eyes. When we do the syringing, absolutely normal, patent. But still they complain watering. Why? Because there is some defect in the medial canthal ligament of the attachment of medial canthal is more anterior, causing a space here so that the tears are accumulated there. So we need to do simple surgery like medial canthal posterior displacement or posterior pexy of the medial canthal ligament. This problem is relieved. This Centurion syndrome, I presented a paper of around 25-30 cases first time from India in the Ophthalmology Journal, International Journal. So I have seen lot of cases and very interesting cases. And this problem will disappear by the boy reaches around 18-20 years, because by the time there is some amount of fat comes here and which pushes the lower lid back and the problem of body clears. So this is very interesting. Again you can see here entropions and ectropions causing heart or any swellings in this area. All the swellings in this area are not lacrimal swellings. There may be some abscess may be there, or this is a lacrimal mucosal. Here it is ethmoidal mucosal projecting into the orbit area. This we can differentiate from this swelling. If it is below the medial campal ligament, it is lacrimal, gravitational. It is above this, it is usually from the ethmoidal sinus. So this is another large mucosal you can see, maybe a tumor. Because of the age, we should suspect a tumors also. So this condition also many people confuse with the dacrocystitis. This is not a dacrocystitis. This is a canalicular abscess. Upper canaliculus is having an abscess. Here canalicular abscess drained completely, patient became normal. So coming to the investigations, we need to do lacrimal probing and canalicular irrigation, that is called syringing. Albert Holmberg's saccharine test, these are all historical tests. Jones dye test, primary or secondary. Dactylocystography, DCT, dactylocystocinematography, microscintigraphy, technetium 99, and X-ray, CT, MRI scanning, and all these things sometimes required, not in every case. Hemoglobin, BT-CT, blood grouping is essential in blood investigations before surgery and ENT examination finally. We should not forget about the last one. So these are the DCT pictures. You can see how the dye is visible like this very clearly, and there is a block here, it stops there. This is the scintigraphy pictures, left one. These are the CT scans showing big tumors here in this area. And this is the nasal various intranasal abnormalities. And coming to the indications of DCR, congenital nasal lacrimal duct block or congenital dactylocystocele, acquired NNDO, chronic dactylocystitis, atonic lacrimal sac, mucosal of lacrimal sac, canalicular stenosis, lacrimal sac fistula, failed DCT, DCR, failed endonasal DCR, just now I did. And after DCT also, at a dactylocystectomy also, we can do DCR. If there is remnant of 1/3 of the sac, a small remnant of anterior part of the sac, we can still do the DCR and make it successful. Because most of surgeons, they cannot remove the sac completely. They refer the cases for the failed DCT cases. I can still do the DCR cases in such case. See here you can see the lacrimal sac mucosal. Either they can be bilateral or unilateral. They reach big space occupying regions. In such cases, the role of external DCR is completely 100%, because with endonasal DCR, we cannot correct these conditions. We need to open the sac from the external side and cut it off as much sac as possible. Leave only 1/3 of the sac and switch the sac to the nasal mucosa. So coming to the contraindications, if there is acute dactylocystititis, you should not do DCR. Lacrimal sac abscess, preseptal cellulitis, active corneal ulcer, lacrimal sac tumors or malignancies, upper respiratory infections, nasal sinus infections, nasal tumors, malignancies, bleeding disorders, uncontrolled diabetes or hypertension or cardiac cases. All these cases are contraindications for DCR. And finally, rhinosporidiosis. Have you heard of this condition, rhinosporidiosis? It is very endemic in Kerala, backwater areas, where there is, you can see the rhinosporidiosis mass appears like this, sprouting from the medial canthal area, or big, if we can reach this big size, you can see the same mass here through the nose also. It is a very dangerous condition. You should not do endonasal or external DCR in such cases. This causes very severe bleeding. Patient can die on the table. You cannot control the bleeding on the table by any means. So better diagnose this condition and leave the patient like that than attempting the surgeries. This is my advice. So other big tumors in this area are this adenocarcinomas and all these things can occur in these lacrimal sac areas. See, even here you can see this. This is a case of this squamous cell carcinoma and meibomian carcinoma, and all the other types of carcinomas can occur in the area. We should take biopsy and bill the patient like that without doing any DCRs in such cases. DCR should not be done. So coming to the types of DCR. Classical external DCR is called Cotis procedure, which is first done by Toti in 1904. This is almost more than 140 years old surgery. After that only this endonasal DCR came. So still it is a lot of people modified. Even I modified the surgery myself, so many modifications. So it is very viable surgery. Somebody asked in the WhatsApp, what is the role of external DCR in the era of endonasal DCR? External DCR is gold standard, more than 140 years old surgery. So still most of the ophthalmologists are very familiar with the surgery and we can get 100% success. Modified external DCR, endonasal DCR, endoscopic endonasal DCR, endonasal laser DCR, intubation DCR, conjunctival DCR, canalicular DCR, transcanalicular laser DCR, and finally post DCT DCR. I just told you, 1/3 of the sac is sufficient for me to repeat the surgery in a DCT, so-called diagnosticomized case. So this is the intubation DCR where you are seeing bicanalicular intubation being done. So coming to the 10 special instruments, Muller speculum I showed you with 2 to 3 teeth each side. There is a unique instrument used only for DCR surgery. Lacrimal punctal dilator, Bowman's lacrimal probes, lacrimal sac dissector, lacrimal cannula, lacrimal sac retractor, cappa I will call it, and nose packing forceps, bipolar artery, lacrimal intubation set, either zones or Crawford steps, and finally lateral bone punch, very important instrument with which I did the DCR. I showed you how to use the punch. So this is the set of DCR instruments. Total cost of this DCR set is only 2,000 or 3,000 rupees. Compared to your endonasal DCR, cost of my total DCR set is that much. This set I am using for the past 20 years. Thanks to my sisters in the OT, they maintain set like this only. They never damage the set. So okay, surgical steps for DCR: nose packing, anesthesia, incision and hemostasis, lacrimal sac dissection, bone punching, nasal mucosal flap, lacrimal sac flap, mucosal anastomosis, syringing of new pathway, skin wound closure finally. That is the why I kept the final one, because there the controversy starts. Scar, no scar. So no scar surgery I think we should do. Okay, then the patient will get attracted back to external DCR. So these are the steps of surgery. You already seen it. So I am just rushing there through. So these are the steps of video. Now already you seen live surgery, so I avoid that one. See, scar. Where is the scar? You may get small scar like it, but out of 3 cases there is no scar. No scar. Intraoperative hemorrhage complications, post-operative epistaxis, damage to neck. All these things you should remember and tackle properly. Otherwise you are scared of all these things and you avoid the surgery. Damage to lacrimal cell. There are a lot of accidents happening on the road, but we never avoid going into the road. We never avoid driving our vehicles. Like this, all the surgeries have complications. We surgeons, we should know them, well aware of the complications, and we should proceed, not avoiding the surgery altogether and referring to somewhere else. Lacrimal pump failure, wound infection, suture granuloma, bad scar, keloid formation may be there if you don't suture properly, fibrosis of the bony osteum, fibrosis of the anastomosis, CSF rhinorrhea, dreaded complication. If you go higher up, you damage the crepidome plate of ethmoid, you will get CSF rhinorrhea, but still it is manageable. You can observe the patient for 2-3 days and nicely pack the nose, and it will subside with high antibiotics and you can easily discharge the patient. There is no, if you require, you can go to neurosurgeon camp. So coming to the final, how to make successful DCR: good case selection, good anesthesia, good nasal packing, good incision, good hemostasis, good bony osteum, good anastomosis, good suturing, good post-operative care. Finally, patient cooperation and surgeons' anatomical surgical orientation is very much important. See, that is the post-op, that is the scar. Thank you very much. I'm here to clarify them right now. Please ask.
What is the youngest age?
The youngest age, I modified myself, the youngest age in the textbooks is 4 years or 5 years. But I did my youngest age, DCR is 2.5 years. Because in Indian scenario, patient having lot of pus coming out, probing failed, he cannot wait indefinitely for the other complications to occur like corneal ulcers and cellulitis and what a cavernous sinus thrombosis and brain abscess and all those things. So better do the surgery and clear the case. Okay. Endoscopic DCR, you can, especially when the patient wants it, wants that surgery only, we can refer the patient to it. Still we can convince them external DCR is having 100% success, endonasal DCR is still 80 to 85% success. So we can tell all these things. They need lot of repetitions endonasal DCRs. External DCR, we need not go for any repetition, lifelong surgery. All these things we convince the patient. But if the still patient wants the external endonasal DCR, he can refer the patient. So the only indication I think, but when the patient is more cosmetic oriented and they don't convince about this scar, if I show the photographs also, they say no, I don't want this much scar also, then that is the indication. Second thing is when there is young patients, when patients are not fit for actual DCR, lot of bleeding and other things we expect, so they can undergo the endonasal DCR. That is another thing. These are 3-4 indications are there. But most of the cases, actual DCR is possible. Failed external DCR. See, a child I do DCR externally 3 years or 4 years. Failed. I revise that why it is failed. Again, taking help of ENT people. Why, is there any small adhesions are forming inside the nose? If they can be easily tackled with endoscopic way. Instead of subjecting the baby for another major surgery, repeat external DCR, that can be posted for the endonasal small surgery and the adhesions can be removed. But many times I observed, once the fibrotic process started, even if you do the endonasal also, they will not help. So we need to put stent in the case. Stent surgery should be, stent surgery can be easily done through the external route rather than internal route. So we keep the stents and the surgery will be successful. Hello? A stent usually we keep for 3 months, 2 to 3 months. So then we remove the stent to the nose.
In pediatric cases, where canalicular abnormality.
In canalicular abnormalities, canalicular stenosis in pediatric cases, we need to put the Crawford tubes only. By canalicular intubation, that is the only answer. Agents is also, totally there is no punctum, no canaliculus means you need to open the caruncle. In the medial canthal area there is a vestigial organ like our appendix. There is a caruncle is there sitting. That we can completely remove. Put the tube from there. That is Jones tube you can put. That is Jones tube is shaped like this. From there you can put it in the nose. That same DCR surgery. That I said no Jones tube intubation. With that patient will get water flowing into the nose because all other pathways are closed. So that's the one.
You said virus is better to use. Nowadays we are doing with a computer, we are managing.
Yes. See, this is what we had very bad experience with when I stayed in Madurai. Lot of Kerala patients used to come to us with this problem. Our seniors and our teachers, they taught us not to touch the patient because that can cause any big bleeding problems. After that, I never seen, after coming to Vijayawada, I never seen such case because that is not endemic in our area. But nowadays, maybe lot of improvements, how to deal with them, they must have come, which I am not aware.
Videos of canalicular connectivity or canalicular
Right now, I am not carrying. A lot of them are there. I improved. I put very simple tubes also. Like on IV set tube, we can cut sterile IV set tube, place it from the lacrimal opening where we opening anastomosis we take now. Just from the anastomosis to the nose, here one suture, there one suture, absorbable suture. After that, we can pull it off. That 3 weeks or 4 weeks, if we keep it, that prevents the fibrosis and ICU. We need not go for costly tubes intubations and other. I will let you cost of, total cost of my DCR surgery is less than 1,000 or 2,000 rupees. We have instrumentation and all the sutures and everything. Sutures also I showed you how to economically put the suture. One suture we open and 10 patients or 50 patients we can use by repeated sending for ET hospitalization. So like that everything can be economized and we can do this DCR for the minimal cost. But there is no, if patient can pay, then we can take 1 lakh rupees also for this surgery. If a rich patient comes, even I can do free of cost also. Thank you.
Thank you very much for your answer. If she made somebody to mobilize around 10 people, her 10 commandments will prevail. Let us hope her inspirational talk will make the ophthalmologists to vengeance into the external DCR.
Sir, not only ophthalmologists, sir, our ENT colleagues also should learn this external DCR. There is nothing wrong. Why can't you people do? Why can't we do endonasal? Why can't you people do external DCR? Everybody should do everything. We need not refer the patient here and there, send the patient. Everybody should tackle this. Only thing is, we are not very comfortable with the endoscope and the cost of endoscope equipment and all that. We are not comfortable. But when we are able to buy a big phaco machine for 12 lakhs, 15 lakhs, 20 lakhs, why can't we buy endoscopic instruments also? I think they are less than 10 lakhs, I think, available.
Hello?
Any legal complication for doing ENT surgeon doing external DCR?
The legal means I can say like that, sir. Sorry, legal means both are wrong.
Hello?
You people also wrong, I am also wrong. I am entering into your field, I am entering into nose, which is not my territory. Why I am doing all this surgery? 25,000 DCRs, who asked me to do? You never given me permission to enter your area, but I did it. Like the same way, you are doing our surgery, you are putting a probe, you are putting a canalicular openings and everything into eye. You are not supposed to touch the eye. You are only ENT surgeons, but you are doing, I am doing. But let us do it in a more understanding way. Everybody should learn properly and do it without complication.
Madam, Sujatha madam. Hello?
Hello, yes, theatre.
Madam,
Yes.
but the present trend is ophthalmologist people are learning endoscopic DCR. I am having so many friends, they are doing endoscopic DCR.
Very happy, sir, very happy. I am very, very happy. And everybody should learn everything. There is nothing wrong. And legal and all, we should not bring. Stupid legal things, I don't believe. Legal, actually we are suffering, doctors we are suffering. Who is helping us in the society? Not even one person said positively about doctor. We are all, everybody beating us and trashing us. One person, they never got up and said, why you are doing all these things to institution doctor? And we are serving them like anything and we are bothered about it. Legal, what legal sir? We should write our own legal things. We should not bother about all these judges and legals and all.
Thank you, madam.
Thank you, sir.
Thank you, madam. Theatre.
Hello, exposure inside. Over to sir.